Yeah, my first, so I'm going to talk about ablative therapies as first-line treatment. There's not a lot of data. I'll tell you that right now. And one of the slides, Brian showed just a snippet of it, that Japanese paper, which included medically operable and inoperable. But we're running a little over, so maybe I can stop early and get us caught up. But anyway, can it really be used as first-line therapy? Well, it will be. There's no doubt about that. And we're going to talk about some of those reasons as we go through the talk. I'm the PI on the Accuray SRS trial, but I have no financial interest and not on the medical board. I get no stock options, nothing, not even an honorarium, sadly enough. I'd like to acknowledge my faculty. Katie, in particular, does a lot of this work for our group, especially the analysis. Arjun Penether is heavily involved in this as well. Neil Christie, Matt Schuchert, we have 18 thoracic surgeons. About 6 of them actually go into the CT scanner room from time to time. Katie's in there probably as much as anybody, if not more. And I've stepped back a little bit from that. The ablative modalities that were talked about by Scott, I'm not going to review that again. Stereotactic radiosurgery, ablative therapies. What's going to ultimately win? Well, I don't think it's going to be one single therapy. I think a lot of different centers will have different approaches. Just like we have different approaches to the surgical treatment of lung cancer, we're going to have different approaches to the ablative therapies for lung cancer. There's no doubt about that. But let's talk a little bit about some of the issues that are facing us. One, covered well, the surgical resection, yes, standard of care, no doubt. But we know the public's seeking other options, as reasons were pointed out, as much of anything, that we have an aging population, smaller nodules are being discovered. No doubt the ablative trials to date have largely been retrospective reviews of inoperable patients. They show reasonable results compared to what? Compared to nothing, basically. In other words, if you can't have surgery and you don't get ablative therapy, what do you get? You get, by and large, nothing. Maybe external beam RT or a little bit of chemo, but by and large, you get nothing. So getting a local recurrence rate down to 30 or 40% in an ablative trial, like many of the RFA trials, the early ones, is not so bad when you consider the alternatives. On the other hand, comparing it to surgery, it's nowhere near. Even a good wedge, we should be in maybe the 15% local recurrence rate, and I think wedges we shoot for today with a better margin, maybe even single-digit local recurrence rates, high single-digit, but nevertheless single-digit. So if we can get these ablative therapies closer and closer to wedge resection, well, that's where we need to be. They're never going to be better than a good wedge, right? I mean, other than perhaps eliminating the morbidity. So predictably, patients and some non-surgical specialties are beginning to enroll now otherwise operable patients, because they're saying, hey, this doesn't look so bad. I'll take a shot at this. What's the worst that could happen? I might delay surgery, but I might have a 60, 70% chance or higher of avoiding surgery. I think CT screening promises to identify these smaller and smaller lesions, GGOs, etc., whereby these ablative options continue to attract interest. So non-surgical ablative therapies are increasingly being used for operable candidates, and we will review these very few trials. Now, are you really surprised about this, that we would see the use of a therapy without a randomized trial? Well, for the cardiac surgeons in the group that did some cardiac surgery at one time, or the residents that enjoy a little bit of history, coronary bypass grafting was largely supplanted in many ways by angioplasty and stents without a lot of randomized data. Then came PERC valves, TAVR, etc. Now, the most recent, I think, event that we've all witnessed is a change in surgery for high-grade dysplasia for the esophagus with Barrett's for EMR. So where's the randomized trial on that? It's not there. So there are multiple examples of these areas where you get a therapy that's reasonable and all of a sudden it becomes possibly a new standard of care for certain subsets of patients. The non-surgical beta modalities we've talked about, so I'm going to skip some of these because Scott and I really didn't share our talks beforehand. So, but are we really there as first-line therapy for using ablative therapies? I'd say to a large degree, no. And the trials that are out there, that, as you're going to see that I'm going to cover, they really didn't reach accrual. The 2 big trials failed. because nobody was very agreeable to taking a medically fit patient and putting him into a trial that has not stood the test of time, and even the retrospective data doesn't suggest that it's as good as surgery. So we're not there yet, and that's why these trials have failed, but it's going to continue. It's controversial, there's limited data, but that never stopped our colleagues in the past, and it won't now. Now, why did we get interested in Pittsburgh? Well, here's a good example of an 80-year-old patient who came to me. This is 2001. And my colleagues were using RFA for the liver. It was a little easier for them because they had an ultrasound in the operating room. They were using ultrasound guided, as many of your colleagues in liver surgery do in the operating room. Pretty easy for them to get their hands on an ultrasound. My neurosurgery colleagues had a CT scan in the operating room, and they let me use it. So I walked in, the tech took me through putting a needle into this thing, and there it was, the needle. We stuck it right in the tumor, and literally this is the first time I had ever been in a radiology suite, a CAT scan suite in the OR, without a radiologist, and the radiologists are not allowed in the OR. The neurosurgeons made sure of that. So, I mean, they totally run it. I called our chair of neurosurgery. I said, well, a radiologist, because no, we don't have a radiologist in there. We run everything. So our neurosurgery colleagues are so far ahead of this, it's really amazing. But as you can see, there's pretty good central deployment of that needle. In fact, I don't know I could do better today. And here it is about 3 years later. And you can see there's still a scar. And many times these ablative therapies leave scars, and that's a whole study in itself, or a whole talk in itself, is how do we decide there's no disease in that? And by and large, it's time and follow-up scans. But nevertheless, this patient did extraordinarily well. And when he initially came to me for surgery, I did a MED on him. He stayed intubated for 2 days. So that was the reason that I chose to do this with little data at the time. This was my first case. He agreed to it. No IRBs, just put him on the table and stuck the needle in, and he did very well. This was my first SRS case. Again, a similar type of case, a very poor candidate for surgery. This was the lesion over here, and after therapy, sure enough, no remaining nodule. You see the little fiducial there in place that we placed ourselves, and had another very good result. So in Pittsburgh, we got convinced that there were subsets of patients that we could cure. So we convinced ourselves that this was real. The question was which patients, which therapy, how much energy, all the other things that had to be sorted out, and to some degree is still not sorted out. So this study was reviewed by Scott for me, and I'm going to move on to the next one, because by and large what we found early on was that we weren't so good as those first couple cases all the time. In other words, getting that needle totally centrally deployed, if you don't, it's just like doing a bad wedge. I mean, you're going to get more local recurrences. And it's frustrating when you're coming from the outside trying to put a needle in the middle of a tumor, and that's why, of course, when you send patients off for CT-guided FNAs, you don't always get an answer. Sometimes the radiologist will say, hey, I can't put a needle in that, etc. Well, it's the same with RFA. It's a very technically demanding approach, and we don't have a robotic arm that puts the needle into this tumor for us. We have to do it manually with what we call CT fluoral. So anyway, this went on to the next study that a little more organized, that was again reviewed. But again, what it told us was we were getting perhaps reasonable at a multi-center trial, but the local recurrence rate was 37%. So we're still not there. And this is probably one of the better trials published on RFA in terms of being prospective. So all I can say about RFA is that we still have a high local recurrence rate. And there are studies, however, that are showing us that with smaller tumors and experience, we're getting better. And I'm not going to spend a lot of time on this last study, but this is a study from Japan. And Kodama looked at a group of very small GGOs, and this was a good follow-up. He had CT scans every 3 to 4 months. Local follow-up was 42 months, so it was really pretty good. And what he found was that a very low rate of local recurrence and a high rate of survival. So I was impressed by this study that, one, choosing smaller and smaller tumors, of course you have GGOs here. How many of these were solid, not solid? I can't tell you that from the paper. It wasn't that good. But anyway, I think we're getting better at RFA. So there's hope for that in the future for small and smaller tumors. Stereotactic, this has been shown, so I'm going to move on. And we also showed our experience with stereotactic radiotherapy. The problem we had initially was the dose, the fractions that you could deliver. So all of the early papers, you're going to see a very high local recurrence rate because we were giving a bioequivalent dose of approximately 60 to 80 gray. And what we found from the Japanese data and others, and this next paper from Japan, they got a bioequivalent dose up to over 100 gray. And ever since then, when we stay over 100 gray with the bioequivalent dose, we're getting high local local responses and failure to recur locally. So when you look at this study that Brian put up, this is pretty impressive data for patients with inoperable and operable disease. In both groups, they did quite well. And again, a lot of it was because they were small nodules, and they also got their bioequivalent dose in multiple fractions up to over 100 gray, which is what we need to do to get good local response and good potential cure. Now where do we go with more recent results? This is another study from us that was published at ASCO and ASTRO. It presented there. 16 centers, again, a large group of more or less inoperable patients. And what did we show there? That we got a pretty reasonable 2-year survival, 75%. And again, this is disease-specific survival. So we're getting better with our own stereotactic radiosurgery, and that was using CyberKnife. And we're getting better with RFA. I still don't think either one has reached the degree of results we have with surgery, and that is why these two studies failed. So this is Jack Roth's attempt, along with Dr. Chang, to put together 2 failed trials. So these 2 big randomized prospective trials on entering operable patients into a randomized trial of stereotactic radiosurgery versus surgery, and basically both trials closed. In fact, the total patients accrued was, I think, 58, and they put these trials together and attempted to make some kind of science out of 2 early closed trials. And you can imagine that scientifically it wasn't so good. However, if you looked at the results, unfortunately the surgery group did do not so well. There were 6 deaths in the surgery group. Overall estimated survival in the SABR group was 95% and only 79% in the surgery group. And this was an operable group, so lots of criticisms of this kind of summary, but nevertheless, using that limited amount of data with non-scientific methods, they did come up with some data that is going to raise some eyebrows, and it was published in Lancet Oncology. So I think thanks to people like Brian and David, a number of critiques were mentioned about this paper, editorials, and it was criticized because both trials failed due to low accrual, low number of evaluable patients, and of course in one trial 26% didn't even have tissue diagnosis before entering the trial. So lots of criticism of those 2 trials and why they failed, but nevertheless the conclusions stand. That is, SABR could be an option for treating operable stage 1. And in a small trial, 2 trials that didn't reach accrual, nevertheless, they did pretty well in the SABR group and didn't do so well in the surgical group for a variety of reasons. Now, there's a new trial planned that I'm not convinced will ever get off the ground. My hat's off to Dr. Fernando, a surgeon, as most of you know, Dr. Timmerman, a radiologist or a radiation oncologist, and they're working together to try to get an industry-sponsored trial up and running, but I'm not convinced that that trial's ever going to take off for the same reasons that these 2 trials failed. So, why are only a few thoracic surgeons performing RFA or SRS for lung tumors? We saw the audience. We see the excitement. Now, you might say, well, that's not a surgical treatment. Gamma knife is owned lock, stock, and barrel by neurosurgeons. You've seen your vascular surgical colleagues in the OR with an interventional suite that they pulled back from interventional radiology, right? Those of you remember that happening about 20 years ago. So what I'm saying is that there's a lot of practical issues. Yes, there's no CAT scan in most ORs. Yes, there's no immediate and easy access to CyberKnife. But I think thoracic surgeons who have perhaps little or no experience have to get involved. And our colleagues in a number of other specialties have done this, so we've got to move forward. How do you do it? Well, that's a whole nother topic that we can cover at another date. But our experience certainly demonstrates that RFA and SRS are safe in high-risk groups of patients that are medically inoperable, but both treatments, RFA and stereotactic radiosurgery, have fallen short in most of the trials to date compared to surgery. But these two randomized trials, they somehow came together and added up 1 and 1 and got 4. But nevertheless, I suspect that larger prospective studies are not going to happen. It's going to be emotions and referral of patients without a lot of science. And I think for us to make a difference, we've got to get involved in these therapies, or we're going to lose a large group of patients that we won't even see. They won't even be coming to us. So anyway, thank you.